Hello, all, and welcome to this month's Simon Says Expert Series. I'm Dr. Lawrence Mark, an associate professor of clinical dermatology here at the IU School of Medicine and a physician scientist at the IU Simon Comprehensive Cancer Center. My research interests are in bridging the gap between clinical care and research activities, so-called translational research. I'm currently involved in clinical trials for new and evolving cancer therapeutics that could be applicable to both melanoma and also my other expertise of cutaneous non-Hodgkin's lymphomas. Today, our focus is on melanoma, which is timely considering that summer is soon upon us. Our expert is Karl Bilimoria, a surgical oncologist and researcher. He is the chair of the Department of Surgery and the J.L. Grossfeld Professor of Surgery at the IU School of Medicine. His clinical practice is focused on melanoma, sarcoma, and gastrointestinal stromal tumors. He has led practice-changing research evaluating the quality of cancer care in the U.S., particularly in melanoma. Dr. Bilimoria, thank you for joining us today.
Thank you. It's wonderful to be here with you to take some time to talk about how the surgical management of melanoma has been evolving and what we have to do to make sure that we keep up with this rapid evolution to make sure everyone receives the benefits of the advances in care. So just a little about me. I am a Hoosier. I am relatively new to Indiana University in this round. I've just been here for under a year, but I grew up in Munster by Chicago. I did go to medical school here, so it's very nice to be back home and enjoying the Simon Cancer Center and the wonderful faculty of IU School of Medicine. This is our Department of Surgery that I'm very proud of. We're one of the largest departments in the country, and we have a very strong surgical oncology division here. It's fun to be back, and race weekend reminded me more than anything that and summer being upon us that protecting your skin and thinking about melanoma prevention is very important. I'm going to talk a lot about the work that our research team has done, and luckily most of our research team moved with me when I moved from Chicago down to Indy, and so I'll be presenting a lot of the work that they have done. So just a little bit of background again on melanoma. It's certainly an important disease. Nearly 70,000 Americans are diagnosed with melanoma each year. The lifetime risk for the average American is about 1 in 50 or 2%. And we sadly still have around 9,000 deaths per year. One of the things that stands out to me the most is that melanoma is second of the cancers in terms of the number of years of life lost because of the early age that it occurs. And when people pass. It's also very expensive. And unlike a lot of other cancers, the incidence continues to increase. This was a study from a while ago, but it still continues to show that melanomas are increasing in the US, particularly thin melanomas. And that's good news, actually. It means that people are going to their dermatologist and early for detection, and we're picking up the melanomas when they're on the early side. So a little bit about the quality of care in the US. And I want to orient you to this graph just a bit, but on this side here, on the y-axis, we have quality, and on the x-axis, we have productivity or efficiency. So things like telecommunications, airlines, banking, all very efficient with a low error rate. We are down in this sector here where we don't necessarily want to be. We are improving, but we are not necessarily that efficient, and we still continue to have an error rate that is higher than most of us would like. But we're not alone. There's another group right here, and you may be familiar with them, but not necessarily the group that we want to be in a quadrant with. So our team does a lot of work to improve the quality of healthcare that it's delivered. This is a landmark study that sort of sets the stage for some of what I'll talk about, but they looked at all sorts of different types of diseases, not just melanoma. And they looked at many indicators of quality, things that patients should be receiving if they're receiving high quality care. And sadly, only about half of patients receive the care that they should be receiving. And so our goal is to try to improve upon that number, particularly in the space of melanoma. There are international comparisons that you'll see pretty frequently that shows that we spend a lot on healthcare in the U.S., but yet we're still one of the highest in terms of deaths per 100,000. And so we have a lot of opportunity to improve the cost of care. Certainly, Indiana is sort of in the middle in terms of cost of care. So we have a lot of opportunities to improve the safety, the quality, the cost, and the outcomes. And so I will talk a little bit about the surgical management of melanoma and then show you how we're working through the quality of care in melanoma. And so there are two components to the typical surgical management of melanoma. So usually when a surgeon gets a melanoma referred to us, the melanoma has actually been biopsied already, typically by an expert dermatologist like Dr. Mark. And we don't actually see the melanoma, it's been removed. But we still have to complete the procedure, and there are two parts to that, typically for melanomas. And the first part is to remove the actual area where the melanoma was a little more widely, so we can ensure that no cells are left behind and we reduce the chance of it coming back. The other thing to do is to check the lymph nodes. If melanoma is going to go somewhere first, it usually goes to the lymph nodes. And so we have a surgical approach for finding that lymph node and checking to make sure that it doesn't have melanoma. The first stage of this is typically what a biopsy looks like. We'll do a wide local excision and remove that area a little more widely. So we go all the way around it with that margin, and the margin depends on how deep the melanoma is. We don't talk about how big around the melanoma is. It's all about how deep it goes into the skin. And then we're able to close this into a straight line. And that's really the first part of the surgery to really clear out that area where the melanoma was. The next part is that we have to look at the nodes. And in really low risk patients whose melanomas are very, very thin, we don't have to do anything to look at the lymph nodes because the chance of the disease going to the lymph nodes is very low with that type of early melanoma. If there's a lymph nodes that are readily apparent and enlarged already, well, then the question is answered and we have to remove those lymph nodes. But there is a gray zone where we don't feel any lymph nodes. We can't appreciate that there are any there that look suspicious on, even on ultrasound or imaging. And so we have to do something to find that lymph node where melanoma could go first. And that's called the sentinel lymph node. And if we can find that, it's an accurate assessment of spread to the other nodes, because if it's going to be somewhere, it's going to be in that first node. Every patch of skin goes to a certain set of nodes, and it's fairly predictable, and we can find those nodes and test them. So how does it work? We inject on the morning before surgery a harmless radioactively labeled sulfur colloid around the primary melanoma. And then right before the surgery, we put a blue dye. And both of those travel through the lymphatic channels and get stuck in the first lymph node or two. We do an X-ray that looks like this. And this is one area where sometimes quality varies from institution to institution. There are some places that are not able to do this or skip this step. It's less common now. But this is really required because you can have melanomas that go to multiple nodal basins, not just one, but this is an example. So here you can see that this is somebody's back. This is their arm sticking out this way and their stomach here. And the primary melanoma is being injected with the radioactive tracer on the back, and it goes to the lymph nodes. And it looks like it might be one side, but actually when you look at them from the back, you can see that it goes to the right and to the left. And so we have to check on both sides then for that sentinel lymph node. They're kind of both equally first. Just because it lights up here doesn't mean that it has melanoma in it. It simply means that if it's going to go somewhere, it's going to go to one of these first. And so again, it can go to multiple spots. It can go to both armpits, like I showed you there, or it can go to the groin in an armpit. It can go to multiple places like that. So this is just diagrammatically how it works. We inject that blue dye, it goes to the lymph nodes, and then we can take out that lymph node. We send it off to the pathologist, and they cut it up and look at every part of it and look at it on the microscope and run some special stains on it. And then we can figure out whether there's any melanoma in that first lymph node. If there's no melanoma, we feel good about that because it won't be in the ones beyond it either, because if it's going to be somewhere, it'll be in that first one. If there is metastatic disease or a little bit of melanoma in that lymph node, then we have to discuss what the management will be. And that's really changed over time. just a little bit about what it looks like in the operating room in case you're curious. We have a handheld probe to find that radioactivity. So this is somebody's armpit with the arm in the air like this. This is what it looks like. It turns blue, but we can also find it with that probe where the radioactivity is. Sometimes there are two. There might be another lymph node as well. So we take out any of them that are sort of equally first. If you imagine a tree branch, there can be two leaves that are sort of equally first. This is the same way with lymph nodes. Here's a nice example of the blue dye running into the lymph node here. And so I was recently operating and doing this procedure in Kenya. And unfortunately there, they did not have the technology for the radioactive tracer. So we could only use the blue dye. And that was very limiting, but we were able to do that. And I'm really happy to hear that after we left, they've done many more of these. So we were excited that we were able to sort of introduce this procedure there. There was a landmark study that was done to make sure that that sentinel node procedure was safe. Prior to that, people would often have all of their lymph nodes removed if there was a lot of worry. So it's kind of only taking out the first one or two gave people some pause. But we have really great data on this because this landmark randomized controlled trial was done and found that whether they were treated with surgery and then you kind of observe them to make sure that nothing bad happened to the lymph nodes and no new lymph nodes popped up with disease versus if you did that sentinel node biopsy right at the beginning, the survival was about the same. The other really interesting part of this study is that about 16% of patients who had their sentinel lymph nodes checked had melanoma in their lymph nodes. This was of a wide variety of melanomas, but 16%. In the group where they watched these patients, they found that over time, roughly 16% developed nodal disease. And so those are exactly the same patients. Just with the sentinel lymph node, they were found early, and here they developed later. Well, that led to an important difference in survival, a 20% difference in survival if you have your sentinel lymph node checked at the time of surgery. And so this really gave us a lot of comfort in using sentinel lymph node biopsy and insisting that it was done early on. This is a beautiful picture. I feel like this should be art that a melanoma surgeon should have in their home. The blue is always beautiful to see in the operating room. Who do we do sentinel nodes for? So we talk about thickness of the melanoma. And so if it's greater than 0.8 in millimeters in thickness, we do a sentinel lymph node biopsy. I can be convinced to do it for people who have a slightly thinner one if there are some other features about it that concern me. Some of the things that the pathologist sees under the microscope, like ulceration or mitoses, showing sort of increasing growth. But the other thing is about age. We know that you have a higher risk of having melanoma travel to the lymph nodes if you're young. And that's, there's not a cutoff for that. It's continuous. But younger patients are higher risk. And so we tend to be more liberal with sentinel node biopsy there. So here's an example of a study that our research team did a number of years ago. But we wanted to make sure that people were using sentinel lymph node biopsy when they should. And very similar to that New England Journal study I showed you, we found that only about 50% of patients in the country, this looked at national data from a large registry, were getting sentinel lymph node biopsy as recommended. About 15% of those patients who should be getting a sentinel node and just one or two nodes checked were getting all of their nodes removed. And then 35% were getting no evaluation of the lymph nodes. And so this was pretty worrisome to us. And so we've done a number of things to improve upon this. In fact, this was so controversial, people didn't believe it, that it could be 50%, but we went back and validated it at individual hospitals that this is actually what was occurring. We looked at why this would happen. So some people would skip a sentinel lymph node biopsy in an older patient, thinking that, that they were elderly and that it may not be worth it, or we shouldn't put them through the extra surgery. But it turns out this is a fairly safe and straightforward procedure for the older patient to undergo. There were some disparities in care. So non-white patients were less likely to receive it when they should. Interestingly, in the head and neck melanomas, people often fail to do a sentinel node biopsy, and that was largely, we think, from our interviews with people, because it's more concerning for people to do that sentinel node biopsy in the neck. They're not as comfortable going and finding the ones, because the head and neck melanomas drain to the neck. And also, if you were treated at a non-NCI designated cancer center. So Simon Cancer Center has been designated as a comprehensive cancer center, as have a number of others in the country, but these places tend to follow the guidelines and provide high quality care more often than other centers. One thing that's come up recently that I thought I would just throw in here is that there is a gene expression profile. This is basically, they can test the genes that are expressed by your melanoma and give you a sense of the risk of the recurrence. What's the chance that it'll come back? And the low risk is 1A, high risk is 2B. And the company is a little liberal with who they recommend this for. We kind of disagree, but people have started using this and without a lot of guidance on how to use it. And so it's led to some changes in the management. This is sort of what the sheet looks like, but it'll, in bold show you up here what your score looks like. But this has introduced new quality issues. People have been using this test incorrectly. They've been using it on thin melanomas and trying to decide whether those are, of considerable risk or not. We get put in a quandary when we have a thin melanoma with a high risk score. What should we do with that? We certainly don't have anywhere near enough data on this yet to know how to use it. But again, it's resulting in quality problems. And like we were talking about with doing a sentinel node biopsy, people are now trying to use this to decide when they do a sentinel node. But again, the data aren't quite there yet, maybe one day. But this keeps my research team quite busy with quality questions to ask about how people are using these tests and how this is changing the quality of care delivered. So when melanoma is more concerning, we may have to remove more lymph nodes, not just that lymph node or two. So sometimes there's a lot of disease in that sentinel node that we take out, and we have to be worried about all the other lymph nodes that they could also have disease as well. But that's not always the case. We do this in a variety of locations: in the neck, under the arms, in the groin, in the pelvis, as well as behind the knee. Those are all places where we have lymph nodes that melanoma could go to. This is where an inguinal lymph node dissection occurs. If the sentinel node was positive, we may have to go back through here and remove all of the lymph nodes. This is somebody's. This is toward the groin here, and this is toward the knee down here. These are the lymph nodes that are involved when people have melanomas in their leg. And the sad part about this is that it can be a very complicated procedure because it can have complications related to infections. It's a dirty spot. It's constantly kind of moving as you move about. It's hard to heal that spot. And so really 30 to 40% of patients have a problem with that. So we only want to do this operation when we really need to. And so we started doing this in a minimally invasive approach. So instead of that big long scar, we put these little tiny ports. They're about a centimeter each, and then we can blow up the thigh and remove all of the lymph nodes. And that's led to a much better approach. But nonetheless, we only want to do this in the right patients. And so this is sort of the next landmark trial that's changed our surgical practice in the last 5 or 6 years. And what has happened is that those patients where we took out that one lymph node, that sentinel lymph node, we put them into two groups. We randomized them into two groups. One where we took out the rest of their lymph nodes, and the other where we just watched them and we did ultrasounds and physical examination. And we looked to see how they did. And it turned out overall, there was really no difference between the two groups. And so that was fairly comforting, that there are probably a number of people who have disease in their sentinel node. And once we take that out, they don't need any further surgery. Now, that did lead to more recurrences in the group who were just observed. So they had a positive sentinel node, disease in the sentinel node, but no surgery. And so and that may be hard to reconcile with what I just showed you, where the survival was comparable. But it shows that if we keep an eye on these patients with a physical examination and an ultrasound every 3 to 4 months, if we find something, we can remove it and give them a similar survival. There was one caveat to this, and we were the pesky group that wrote a letter to the editor about this. The patients who were in this study had very, very little disease in their sentinel node. And even in that group, I showed you there was a recurrence rate. So you can imagine if people had more disease in their sentinel node, these results may not apply. So the trial, you can imagine if people had lots of disease in the sentinel node, doctors may not have been as willing to put their patients into this study, or patients may not have been willing to enroll. So really it was people with just the slightest amount of melanoma in that sentinel node. And so we don't want to extrapolate the results of this study beyond patients with just a little bit of disease in their sentinel node. And so the current recommendations are that lymph node dissection, CLND is completion lymph node dissection, is used very selectively. And so we had looked at this many years ago. This was before that study came out. And again, we found that only about 50% of patients were getting the right care. And again, this was a very controversial paper when it was put out, but we validated it with on-site assessments looking at what actually happened in the medical record. And similarly, older patients, those treated at non-expert centers, and actually in this case, it was the lower extremity melanomas, because doing a dissection in the leg, like I showed you, is less sort of favorably looked upon by surgeons than doing it under the arms, because the lower extremity ones in the groin have more complications. But so all of this put together, we have new issues in quality, right, that our team will again start to study and look at, where people may be incorrectly extrapolating the data of that trial to patients with a lot of disease. And we are seeing these patients, and we've talked about them in our melanoma tumor conference, where people did not remove all the lymph nodes despite the patient having a lot of disease in that lymph node. And then they come back with a recurrence. And so we still continue to have people who aren't using the data correctly as well, and they haven't quite adapted. So people with small amounts of disease are still getting all of their lymph nodes removed. And so we continue to work on this and study this and provide information to the community about how to align with the best practices that we know about. Becoming a melanoma or being a melanoma surgeon these days is far more interesting and complicated. We have to think about the molecular makeup of the melanoma, and whether there are some treatments we can use on the front end before surgery to sometimes shrink down the melanoma and make our surgery more effective. So that's become, quite interesting and enjoyable to have these good therapies to use. And sometimes that's not intuitive. So treating patients with therapy before doing the surgery, everybody just wants it out right away. But it's very wise sometimes to do treatments for certain patients in advance. It's not a delay. We actually treat the whole body. It turns out to be very effective. And again, it shrinks the tumor down frequently and makes it a more successful chance of getting all of this melanoma out for us. And the rates of getting a complete response with this are pretty good. When I won't bore you with all the different types of treatments, but giving these treatments up front can result in a lot of the disease going away, and again, making the surgery much easier. We've taken a few approaches to try to improve the quality of care. I showed you that a lot of times people don't use the recommendations, and so we've done a lot of work to disseminate those guidelines to people who treat melanoma. We collect a lot of data and then provide that back to hospitals and cancer centers. Ensuring quality care has even been tied to reimbursement in ways, not necessarily for melanoma, but for other diseases. And so you can get a lot of data. We're a Commission on Cancer hospital. There are about 1,500 of those in the country. You have to go through specific requirements to get accredited, but then you get all of your data back, and it's benchmarked compared to other hospitals. This is not ours. This is just an example hospital, but it shows you if there's a particular measure, what % of your patients are receiving the correct care on that measure compared to other hospitals. And the graph looks something like this. And so if you're this hospital here, you need to do a lot of improvement to reach these hospitals, which are providing high quality care nearly 100% of the time. The problem with these systems is that they're still retrospective, right? We're collecting the data and then feeding it back. It doesn't help the patient that's right about to undergo treatment. And there were relatively few measures for melanoma at the time. And so our team has done a lot of work to develop these measures. We've also tried to build these things into the electronic medical record so physicians get a reminder about the right things to do. We assembled a really outstanding international expert panel and went through a process to develop these measures, on multiple rounds of sort of evaluating quality measures and developing them and voting on them. And this was resulted in 55 measures that Commission on Cancer now uses a number of these. This is an example, though. These are the number of hospitals that adhered to, in this case, if all of the measures. And so none of the hospitals actually at this time, when we studied this, were adhering to all of the measures. Everybody had some room for improvement, but on average, about 50% people were, the largest number was that they were adhering to 50% of the measures. This has gotten much better over time. And so we've been happy to see that. So the next steps for improving care are to continue to feed back data to these folks, continue to build it into the workflow for physicians. And now there are even guidelines for patients. So patients can go to the NCCN data. NCCN is different than the NCI that I talked about. The National Comprehensive Cancer Network is the group that develops guidelines. Dr. Mark is our representative to that group. And they set the standards for care in the US. And there is a patient version of those guidelines as well. And so those are very helpful to both now provide good information to patients so they have that as they seek care and get really involved in their treatment decisions. So just a little bit of an intro to the surgical management, how things have changed, and how we make sure through our research that patients are receiving that evolving best practice care throughout the country. And so happy to open it back up to Dr. Mark and for any comments and take some questions.
Well, that was an awesome presentation, and I'm so happy that we do have you here as a champion for best practices. Having best practices in medicine over and over has been shown to give patients best outcomes while still being the most cost-effective way to proceed. We also have some questions, if we have time, from our audience and folks who would like to learn a little more.
Right.
One of our questions that we've gotten is an interest in any new treatments on the horizon. Particularly, they were asking about a vaccine or the vaccine trials for skin cancer.
Yeah, so there are vaccines being developed, and they are now in clinical trials. They are applicable to certain populations, so they're not for everyone, but they hold a lot of promise. Melanoma is a disease where kind of encouraging your own immune system to help fight off the melanoma tends to be very successful. That's a lot of the therapies that we have right now, both the ones that you can, that are given systemically to your whole body as well as injected. So the idea that a vaccine would be successful makes a lot of sense, particularly for melanoma, even above other cancers. And so we're very hopeful, but a lot of work to do. And we're hoping that we will get our Simon Cancer Center soon enrolled on one of those trials.
It is an amazing field in that we really have been trying to identify melanoma vaccines for several decades, but it has only been more recently that we've understood the immunology and pathology well enough that we are starting to make actual headways to things that might actually work. And so we are looking forward to new vaccine trials. But that also kind of leads us to another question of, well, what are these advances in immunology and specific drugs that we now use to immunologically treat melanoma? And in fact, the immunology of melanoma has been a game changer and has altered outcomes and increased survival for those with metastatic melanoma in ways that we never could have imagined, say, 20 years ago. Do you have thoughts, anything you'd like to add, Dr. Bilimoria?
No, it's well said. I think the new immunotherapy that's become available over the last decade or so has really, again, it basically fires up your own immune system to help fight off the melanoma. and finding ways to keep the immune system identifying melanoma and fighting it off has been the focus of these various drugs. And so we're just kind of getting started. I think there'll be many more that come along. But we went from a disease that really had no systemic therapies, and really surgery and maybe a little radiation were options, but really surgery was the mainstay, to completely transforming the disease over the last decade. So it's been a lot of fun to be in this field, and constantly, every year some new advance happens that changes how we practice. So it's just been a lot of fun to see it happen, and it's great for our patients.
And that being said, even immunotherapy is not for everyone because it does activate your immune system. Despite our advances, I'll say that we have a big hammer right now, and we'd like to have more surgical precision in our therapies, even medically and immunologically for melanoma, which of course the vaccines are that next iteration. But if say you had a severe or life-threatening rheumatologic disease or other autoimmune disease, you wouldn't be a candidate for immune therapy, because we want to save you, not kill the patient. So we have to be judicious about how it's used at this point in time. We had a few other questions. This is a good one. If you've had basal cell and squamous cell skin cancers, does that make you more prone to develop melanoma? And maybe I'll take that one. Yeah. In that having basal cell and squamous cell carcinoma is typically, not for everybody, but typically a measure of how much ultraviolet exposure you've gotten over a lifetime. And so, yes, there is a correlation, as excess UV is also associated with development of melanoma. And so folks who've had basal cell and squamous cell carcinoma, we keep a closer eye on with skin checks and surveillance. And often we find a melanoma, hopefully early, when you're already in a surveillance mode. We also have one more question. Let's see. When should we assume is the end of worry time after you've had your melanoma removed? Say someone had their melanoma removed decades ago. Should we assume, well, now I don't need to worry about recurrence?
Yeah, so we have a follow-up approach where we have you alternate follow-up with the surgical oncologist and the dermatologist over the first 5 years. And it starts to spread out a little bit over that time. So it might be, you might see one of us every 3 months during the first 2 years, every 6 months during the third year, and then maybe annually after. But that can vary depending on the type of melanoma you have. And then afterward, you may not need your surgeon quite as much. And that we think that the worry is a little less, but you will need your dermatologist for your life, is what is our approach. And so I'll let Dr. Mark comment, but that is you need to make sure that you do not develop another melanoma and have someone experienced just keeping an eye on where the prior one was. Melanoma can sneak up in later years, but it certainly decreases every year that you are melanoma free after surgery.
Very true. As I like to tell patients that your highest risk of recurrence really is within the first 2 or 3 years after your initial surgical intervention, and actually continues to taper off and get lower and lower risk of finding a recurrence down the road. But still, it never goes to absolute zero. And so a yearly skin check with an expert, someone who can truly identify if something is going awry, is an important thing to keep up on. And that may relate a little to, I think there's another question that came in where someone celebrated their 5-year anniversary of being melanoma free after their excision. But we oftentimes have a fear that, well, is there another one that's going to arise, or is this one going to show rear its ugly head again. And so what ways can we do better about identifying the recurrence, or what ways are there any blood tests or any other definitive tests to identify if you still have melanoma in you? I think I can start that one off in that there is, and the data would suggest there's nothing better than a physical exam and a review of systems from a doctor who knows what they're doing in the melanoma realm. Now, you might be able to identify new melanomas with photographic, so whole body photography if you were a very moly person, but only a few people I actually would think would fall into that category who are just so moly I can't follow them effectively. But I don't know of any particular blood test. And I always like to add that a CT scan or PET CT, unless we know you have a obvious metastasis that's still lurking about, they're really not, that's not how we identify a recurrence. It is that physical exam, review of systems, lymph node survey with fingertips, feeling for those nodal basins. That is the best method. Did you have anything to add, Dr. Bilimoria?
No, I agree. There is not a blood test. We hope one day there might be, but there certainly isn't. And patients do often ask for PET scans or CAT scans to just keep an eye, but those aren't without their risk, right? They have a lot of radiation that they deliver themselves. So if you don't need it, you shouldn't get it. And so depending on the type of melanoma you have, your physician will counsel you on whether there's value in that. But certainly even that generally ends by the 5-year mark for most people once they're free of melanoma.
I wouldn't even say that the radiation is the risk. The risk is what we call the incidentaloma. Hey, I got this scan and they identified this thing in my lung, and you get this big workup with very dangerous interventions, whether it's a lung biopsy or whatnot, and just to find out, oh, I'm sorry, it was a benign whatever.
Yeah.
And so sometimes the scan is riskier than you having disease recurrence, and you have to weigh that very carefully.
Certainly. I think there's a question here that looks like it's right up your alley to talk about prevention.
A little bit more about prevention. Yes. Well, you can't change your past, but you can at least avoid adding insult to prior injury, is how I put it. And that would be, well, you've got your sun protection, sunscreen, about the right times of the day. I got to mow my lawn. I do it, but I have some sunscreen on my exposed body parts, and I do it, say, in the evening, or probably too early on Sunday morning before the sun is really up and I bother my neighbors, but nonetheless, for my own safety, that is the way to do it. So avoidance, protection, appropriate clothing, right times of the day. There are fabrics that have sunscreen protection in them. UPF is what they call it. And they are effective. And you can get those at many of the sort of, I guess, camping type stores. I won't mention any names here, but camping type stores will often carry them. And some of the online vendors for camping equipment will also have good quality, airy, breathable shirts and hats for protection with UPF embedded in them.
Yeah, I've been happy to see a lot of the golf attire now has UPF embedded. So anywhere you might get golf attire, they could have that as well. And then sunscreens, we certainly encourage sunscreen use. The key is always reapplying it with frequency. And, now in this country, through actually the lobbying efforts of the patient community, these sunscreens are what we call broad spectrum. They cover both types of UV rays that you can get. And so if you're traveling abroad, you might want to just make sure that you have broad spectrum sunscreens, and that's what you're using. But luckily here in this country, most of it is that. So the number on the sunscreen is a little less critical if you're kind of in the middle range, as long as you're reapplying regularly.
Yeah. We may actually have some newer sunscreens that'll come along as the FDA approves that have been approved in other countries, but we don't have here. So we'll look forward to that too. We probably have at least a couple more minutes. So I think there's one more question that we may want to get to, which is a crossover between the dermatology and surgery world, asking what's the role of Mohs surgery? What is Mohs surgery? And how does that compare for plastic surgery and what we do for melanoma care?
Yeah, great. So Mohs surgery is done typically by a Mohs surgeon. They do specialized training in this procedure, where essentially they can take slices of the tumor or under the tumor and continue to take slices, look at it under the microscope, take another slice, look at it on the microscope until they kind of get it all. And that's a very effective approach for some types of skin cancers. And so, and at the end of that procedure, you can imagine that there is a defect left, a hole, for lack of a better term, that has to be fixed. It's not applicable for all melanomas, but if you were for other skin cancer types, that can be then reconstructed by either a general surgeon or a plastic surgeon. But it does have to, usually benefits from being closed in a cosmetically sensitive way. We do like to use these for some types of melanoma as an initial step, because you can kind of map out where the melanoma is and make sure you kind of get it all. And then that's what the Mohs surgeon does. And then the surgical oncologist comes in and goes even a little bit wider and then closes it in a cosmetically sensitive way.
Yeah, typically it is a dermatologist that does Mohs surgery. It has its particular utilities in tumors that are what we call contiguous, meaning they grow as a solid mass, so you can check the edges. One of the things about melanoma, however, is that it can have skip areas where it has microsatellites at the edge, which Mohs surgery would not effectively identify. So we are currently, across the nation, we have studies ongoing looking to see how effective and safe is Mohs surgery for melanoma care, given that at least we're thinking about that. It may not end up being a major issue for doing Mohs as part of the surgical procedure, but we want to be careful about it. And so those studies are underway. Many of your Mohs surgeons are actually cosmetically trained also, such that they will close the defect and won't require going to the operating room with a plastic surgeon. However, if the defect or the hole is so large for patient care and safety, sometimes they do need to go to the operating room for effective closure or certain grafts and flaps to be able to be performed. Certainly your Mohs surgeon would only be working on a thin type of melanoma anyway, because they wouldn't have in the outpatient setting the ability to do your sentinel lymph node biopsy. So things to think about. I think that may have been our last question, Dr. Bilimoria. I want to thank everybody out there for having joined us for this month's Simon Says, and also give a plug that you can see a recording of today's session and the information about upcoming sessions at cancer.iu.edu/Simon Says. Thank you all.